Hi folks, I'm Bob Schrupp, physical therapist.
Brad Heineck, physical therapist.
Together we are the most famous physical therapists on the internet.
In our opinion, of course, Bob.
Brad, we just did a video on anterior hip approach for total hip replacement.
Sure.
And now we're going to do one on posterior hip approach procedure and also the precautions in the home exercise program that you're going to do.
Yep.
So,
We've done these before, but they were condensed, so these are a little more
expanded.
Yep, more comprehensive, give you a little better idea. If you're thinking about a hip replacement, this is a great video to watch, and then watch the anterior, and you'll get a really good idea of what's going on.
Yeah, which way to go. And
exactly.
And talk to your surgeon, obviously, too. By the way, if you're new to our channel, please take a second to subscribe to us. We provide videos on how to stay healthy, fit, pain-free, and we upload every day. Subscription button here or there. And also wander over to Facebook and give us a likey.
Likey.
I likey Mikey. Remember that? Wasn't I like Mike?
No, I don't remember.
Michael Jordan.
I don't remember any of that,
Okay.
Bob.
Like Ike. If you're really old.
Let's get on with the program, Bob.
All right, let's take it away, Brad.
Okay, posterior hip. This is posterior hip. What is behind? The back side is posterior in medical terminology. So anterior, they come in from the front. Posterior, they come in from the back. And there will be some where they kind of come from more posterior or lateral posterior. Typically, from
That's still posterior, though, right?
Right. The precautions, from my experience, are the same.
Sure.
And again, we always look at what the surgeon suggests as well. We go through the discharge surgery notes and make sure
Brad makes a really good point, because if there's any variation, they might make some other suggestions. And they also, it's different from surgeon to surgeon. I worked at a hospital where they had 10 surgeons, and each surgeon had their protocol.
Right.
Because each one wanted to be a little bit different.
Right.
So.
And that's their choice.
Their world.
They got some big responsibilities. Okay, so here we got Napoleon laying down on the surgery table.
Napoleon, bone apart.
Bone
apart.
Yeah. Sorry. Okay. Anyways, so here we've got Napoleon here. If he's laying on his back, you're not going to do a posterior approach.
Right.
The patient has to, and I'm not an expert on this, but from what I understand from the little research I've done with the surgery itself, is that the patient's laying on their side like this, and you can see if you flex the hip, they can open up the hip here, and it's wide open. They have to get the prosthesis, which is metal, so they put a new metal hip in, and there's actually an anchor that goes down into the femur.
Sure.
Okay, and so they have a lot of room to work with that, and it's not near as convenient on the anterior.
The one
approach.
I saw 30 years ago was on their side.
Sure.
Yeah.
Yep. On their side, and then you have to get in and take off the acetabulum or the ball or the socket. I'm sorry, and then they put in. That's typically a plastic type thing.
Right.
They do have metal on metal. And that's something you need to discuss with your surgeon. They'll lead you.
They'll go into that.
Yep, exactly. But anyways, they do have to go through quite a bit of soft tissue and muscle, and that hip extensor, the gluteus maximus muscle, they're cutting through that tissue. It's not a big deal. They get through there. They replace the hip, put it back in. Typically, it's cemented in, and within an hour or so, it's hard as it needs to be.
Yeah.
When the patient gets up from the surgery, they're able to put 100% weight bearing on it. It's solid.
It's more what they can tolerate. I mean,
Exactly.
What the muscles and been cut through, so what they can tolerate.
Exactly. So it's and they've been doing many more of these than anterior.
Years and years. Yeah.
The big drawback as far as the patient is concerned is the precautions.
Right.
What do you have to avoid or not do so you don't dislocate and get the socket to come right out of
the ball
right out of the socket.
That's your biggest concern.
Right.
Is that beyond an infection, I suppose, which you rarely see.
Exactly.
Is probably a dislocation,
Sure.
which I've seen. I bet you I've had 10 of them.
Right. That's not bad considering there's thousands of these done
I've seen thousands
in every
of
hospital.
people with hip replacements.
So this is something that is a big reminder. So we're going to get Leopold out of the way here. Napoleon, Leopold, whatever. Good old bonehead. Sorry about that. Are you ready, Bob?
Yeah.
Okay.
Heave ho.
1, 2, 3. Oh, he's lost some weight, Bob.
Yeah, he's going to lose a knee there, too. Yeah.
Okay.
Thanks for helping out.
After surgery, they will inform you of this, and the therapist is going to quiz you again and have these memorized. So you can memorize them before surgery is a good idea. So start right now. The big one, would you say the biggest one is no hip flexion greater than 90 degrees, but the layperson has no idea what that really means typically.
Right. Why don't you sit down once, Brad?
All right.
So we're looking at a 90-degree angle between the trunk or his upper body and the thigh here. So a 90-degree angle is a right angle. So if we got a line here and a line here, you don't want to have more, that's less than 90.
Right.
Now we're going, now he's at 100 back here.
Right.
And now right here is the right angle, so you don't want to go beyond that, which means you can't do any bending forward.
So you cannot bend forward to tie your shoes. You cannot bend forward to put your socks on, to put your pants on.
You can't bend forward to get out of the chair.
Exactly.
Which is really difficult to do because you got to get up straight.
Right. So that means you're going to sit in a chair with armrests all the time.
Right.
Okay. So you're going to get down and you're going to scoot your bottom forward, use the armrest, and go straight up like this.
Yep.
Okay.
Tell the story about the patient you had.
Right. One of my patients, she was doing, actually she's a few weeks out doing fairly well. She went, as a matter of fact, she went to Perkins with family members in a booth. That's a place to eat. She went in one of those booths and she slid out of the booth and she was going to try to get out. It's kind of hard out of a booth compared to a chair. She popped it right open, right in the restaurant, called the ambulance come in.
She might have even been rotating a little bit too on that.
Right.
She might have been turning it out.
Exactly.
Or turning it in.
Turning it in.
Yeah,
right.
turning it in.
So that's a big thing, is don't do that. And maybe that story will help fuse that into your head.
Yeah, because the one that we spent, like I said, they spent a lot of time showing you how to put your shoes on and socks on with sock aids, and also the extended shoehorn, so that you wouldn't be doing it.
The other one that you may not think about is laying in bed. You can bring your knee up like this. You can bring your knee to here, but you cannot go farther than this.
Right.
Particularly if you bring it up and over this way, then you're really stressing that, and you get a good pop that baby right out.
And again, between what I've seen over the years, Brad, is people tend to dislocate it in bed or while they're standing, and we'll show you what they're standing. But right now, lay on your side once, Brad.
I've got to get my mic out of here.
Get his mic out of the way.
Oh, there we go. So if you're laying on your side, let's say this is the hip that was replaced.
That's the problem hip.
Because you usually don't want to lay on it because it hurts because it's been surgery.
Right.
Operated on.
So normally you want to have a pillow between the leg, or sometimes we have what is called a...
Here, let's show the improper first.
Okay, sure.
So, if you go like this, it's stressing the hip, but if you go down like this and over, then it's really putting a lot of stress on it, because you might even get up past that 90, and the more you're up here and down here, the more likely to
or even may come off the bed like this.
And you bet.
Goes the weasel.
There you go, call 911.
Yeah.
So
a pillow, or sometimes they actually make a hip abductor pillow that we actually put, and then it comes with straps.
Yep.
Sometimes they put people in a knee immobilizer.
Sure.
The whole leg is immobilized, so they can't have less of a tendency.
After surgery, the first few days, you're going to be sleeping on your back. You're not going to be rolling side to side. That's typically like when you go home. Oftentimes, the hip surgery is a 2 or 3 night stay. They're getting better at them. I'm not sure if they're going less than that.
We just had a patient, Brad, that he has some dementia, so he doesn't follow precautions.
Sure.
Dislocated his hip 3 times in bed. And
oh my goodness.
Yeah, so that we got to the point, he had a knee immobilizer, he had then they put a hip spica brace, and then they put a pillow between the leg too.
I have had a person who had a hip replacement. She was under 40 years old. I don't know, it was 35 or 36, and went quite well for her. She's limited somewhat on her activity, but generally, as normal. She's not playing tennis or skiing, downhill skiing.
Show the other way people tend to dislocate it when they're standing.
So the other thing is you don't want to internally rotate your femur or your thigh.
His foot's turning in like this.
Right.
So that when the foot turns in, the whole hip is turning in.
Right. So that puts pressure right on that surgical site. Usually it's not a problem when you're in bed because you can't get a lot of force on it. But if you're standing here like this, let's say you have your cane here, this is my new hip leg, and I want to turn to the left, I go like this, and I don't...
Yeah, he doesn't pick
I don't lead, and I turn like this.
He anchors the foot.
and then that puts a lot of stress on that joint. You got weight through it, it's going the wrong direction. Ew, it's not good. So when you're walking right afterwards, you know,
Always picking up the feet.
Oh, yep, exactly.
Doing the shuffle.
Yep, not taking big turns, big steps.
You don't want to bring the foot over this way either, Brad, do you?
Right, yep, we're not gonna go over like this because that crosses the leg, so no hip abduction, but that means no cross the leg.
Right.
So typically, you know, you're not
don't
gonna
wanna
sit
do
like
that.
this, you're not gonna sit like this, so don't cross the leg, don't point the toe in, and do not go forward greater than 90 degrees, which is upright and tall. You're gonna learn good posture.
So you got to be careful getting out of bed too.
Right.
I mean, you want to get off. Want to show Brad?
So here's my
is the
hip.
This is the hip.
Yep, that's the hip. So here, you're going to do the log rolling thing.
Right.
Here, of course, you know, later on you'll be able to roll on it and it won't be
Right.
painful.
And then push up.
Right.
A lot of times, sometimes that's where people need help is to get out of bed initially. Because
Right.
And a lot of times they have the bar or the
Trapeze.
overhead trapeze.
Right,
Yeah.
exactly. Or the bar, you know, the hand rest right on
Right.
the bed itself so you can get some better adjustment and control.
You want to show a few exercises, Brad?
Sure. Naturally, Bob. We're therapists. Exercise is what we like. So starting out, you can, if you're still using your walker, you got it handy.
By the way, we always decorate our walkers.
Yeah, look, isn't that something?
When in doubt, look up. It's a
Okay.
heavenly reference, right?
Exactly.
So,
So we're going to do some marching.
okay, not above 90,
Right.
so it's just going up to
Right to there.
And you wouldn't be able to probably go up
Typically,
any
that's not a problem. It takes a
Yeah.
lot of effort. So we just get them up to here. You're going to do some hip abduction.
higher. Forward, he's not turning it out, he's not turning it in.
Right. Which is hard to turn it. I mean, you could turn it out. It won't hurt the
It
hip.
won't hurt anything, but,
But it's not the right way to do
it's
it.
not strengthening the right muscle
Yep.
then.
And then we'd like to do hip extension like this. And we're doing 10 to 15 reps of these typically to get started. Not like this, but good tall posture and work just that hip muscle. Because when you lean forward, you're compensating and you're really not making the exercise worth doing. Same with this one if you're going out to the side. Don't do this. Trunk up straight, out to the side like that, and then squats. Okay, I like to have my patients particularly.
Chair behind you.
Yep.
For safety reasons.
Chair behind in case you squat too far or you lose your balance, you're safe. The other thing is people at a higher level, younger people that may squat too far because they're really go-getters, you put a chair there and they can't go past the 90 degree.
Sure.
So it can be a reminder. Sometimes I'll put a pillow
Even
under
a
there.
pillow in there, exactly.
Exactly. So we get that height right.
Okay.
Okay, and then always some balance stuff.
So now we're looking down at his feet here. Mm-hmm. This is where the exercises are going on. We talk about we need to rehab the whole leg, not just the hip, because the quads have gotten weak, the calves have gotten weak, anterior musculature
Right.
has gotten weak.
So that's a good initial one for balance. And as things progress, you'll probably need a therapist if you're going to be doing higher level activities, you know, outdoor activities, whatever, you know. They'll show you more advanced exercises. We're going through the beginning things. So, wow, Bob.
All right. Brad, remember, we're not just pretty.
We're pretty ugly, and don't
No,
forget
we're pretty
it.
handy
Oh,
and
that's
helpful.
right.
We did it right this time, by the
Yeah,
way.
we're pretty something. Anyways,
Yeah, we're pretty something.
be careful in everything you do and have fun.
Okay,
I don't know if you
thanks.
can do both though, Bob. Be careful and have fun.
I don't know. We'll find out.
Let's see what they do.
Thanks.